Indian Health Service within the U.S. Department of Health and Human Services. Rear Admiral Weahkee is an enrolled member of the Zuni tribe and previously served as the Chief Executive Officer of the Phoenix Indian Medical Center. He grew up in Shiprock and began his professional healthcare career in the United States Air Force. Please help me welcome Rear Admiral Weahkee.
All right, good afternoon. This always seems to be my time slot, the right before lunch and tribal leader discussion. So, we'll get a healthy lunch? Well, good morning, everyone. It's an honor to be here, and I want to thank the National Congress of American Indians for inviting us to provide some comments and updates on the work going on across the Indian Health Service. I'd like to thank especially NCAI President Jefferson Hill. I know he's not here, he's probably somewhere close by. On behalf of HHS Secretary Alex Azar, for his service and commitment and a distinguished career of leadership and sacrifice for our American Indian and Alaska Native people. I want to also thank all of those appointed members to HHS Secretary Azar's Tribal Advisory Committee who are here at the executive table with us, including President Keogh, but also Chairman Aaron Payment is also on that committee, as is Chairman Ron Allen. So thank you both for your leadership as well. I want to thank all of those who are in this room, and I see many familiar faces, who serve on any of the various HHS tribal advisory committees or work groups. Thank you for your sacrifice and dedication. The theme for this conference, Sovereignty in Action, reminds us of the uniqueness of the nation-to-nation relationship that exists between tribal nations and the United States, and our shared goal of promoting self-determination and self-governance. On behalf of the Indian Health Service, we appreciate all of your input and assistance as we work together to advance healthcare services and to protect and honor tribal sovereignty. Our positive partnerships and relationships are critical to our shared success. We remain strongly committed to working with all tribes, tribal organizations, and with our urban Indian organization partners. We believe in and we are committed to regular and meaningful consultation, urban confer, and collaboration. Our collaboration with NCAI demonstrates an important aspect of our newly published strategic plan, specifically to build, strengthen, and sustain collaborative relationships that advance the Indian Health Service mission of raising the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. We recognize that elected tribal leaders and tribal health team members are in the best position to understand the healthcare needs and priorities of their communities, of their families, and their tribal citizens. Today, tribes and tribal organizations administer more than 60% of the Indian Health Service appropriation, primarily through contracts and compacts authorized under the Indian Self-Determination and Education Assistance Act. The number of success stories grows each year, and the IHS supports this success by offering information, technical assistance, and policy coordination. I'd now like to take some time to provide a brief update on some of the current work going on across the IHS. Just last week, the Indian Health Service awarded funding totaling $15 million to 8 tribes and tribal organizations as part of a competitive small ambulatory program to fund construction, expansion, or modernization of small ambulatory healthcare facilities. The IHS Office of Environmental Health and Engineering manages this program, which support tribes that are working to expand access to various outpatient services for their patients. This includes offering new services, expanding existing services, or upgrading outdated facilities. Since the program began back in 2001, more than 49 different projects have been funded, totaling more than $74 million. These facilities are an important part of the Indian Health Service system, and the program is a way to help our tribal partners expand access to quality health care for Native people. The Indian Health Service Office of Urban Indian Health Programs also recently awarded just over $1 million to the National Council of Urban Indian Health for the Urban Indian Education and Research Program Cooperative Agreements. NCAI will provide services and education to the 41 urban Indian organizations throughout the country located in 22 different states in 5 different programmatic areas. And this program will help urban Indian organizations to build capacity to meet the needs of their communities across Indian country. We also recently awarded to 9 tribes and tribal organizations nearly $1 million for 2019 through the Tribal Management Grant Program. Our Office of Direct Service and Contracting Tribes manages this grant program, which consists of 4 different project types, including feasibility studies, planning projects, evaluation studies, and health management structure development. So I want to say congratulations to those tribes and tribal organizations that were able to receive funding through these various mechanisms. I also want to share and highlight a few of our ongoing activities. One of the goals of the new Indian Health Service Strategic Plan is to ensure that comprehensive, culturally appropriate, personal and public health services are available and accessible to American Indians and Alaska Natives. In our focus on improving access to care, 2 examples of our work includes ending the HIV epidemic in Indian country and our efforts to address the opioids epidemic. Starting with our work related to the Ending the HIV Epidemic, a Plan for America initiative. Back in February, during the State of the Union address, President Trump announced his administration's goal to end the HIV epidemic in the United States within 10 years. The initiative aims to expand partnerships between the IHS and Native communities to end the HIV epidemic in Indian country and work to eliminate hepatitis C. This new initiative will enhance IHS's ability to support existing programs and to reach those people who have not yet been able to reach. This initiative will also leverage the powerful data and tools that are now available to reduce new HIV infections in the United States by 75% within 5 years and by 90% by 2030. Earlier this month, we announced the award of $2.4 million to 9 tribal epicenters to support American Indian and Alaska Native communities in reducing new HIV infections and relevant comorbidities, including hepatitis C and sexually transmitted infections. The tribal epicenters will participate in both regional and national level coordination. They'll provide technical assistance and prescription and disease surveillance support to communities, and they'll support the development of community-specific plans. Through our National HIV Program, the Office of the Assistant Secretary for Health Minority HIV/AIDS Fund provided $1.5 million to Cherokee Nation's Ending the HIV Epidemic pilot project. This pilot project provides an opportunity to begin implementing and evaluating some key foundational activities that will help to accelerate progress toward ending the HIV epidemic across all of Indian country. While efforts to end the HIV epidemic in Indian country are not new, what is new is this coordinated, focused national effort to end the epidemic. Today we have the tools available to us to actually achieve that goal through teamwork with the Indian Health Service, tribes, our urban Indian organization partners, with the support of our sister federal agencies, and in partnership with the Native communities that we serve. Another example of our current work to improve access to care includes our efforts to address the opioids epidemic. HHS Secretary Alex Azar identified addressing the opioids epidemic as one of his top 4 priorities when he took office. And helping to guide our efforts within the Indian Health Service is the Heroin, Opioids, and Pain Efforts, or HOPE Committee, which exists to promote appropriate and effective pain management, to reduce overdose deaths from heroin and prescription opioid misuse, and to improve access to culturally appropriate treatment. IHS recently concluded tribal consultation and urban confer to seek input and guidance as we develop an opioid grant program to distribute fiscal year 2019 opioids funding. The 2019 Consolidated Appropriations Act provided a $10 million increase to the IHS alcohol and substance abuse program budget to better combat the opioid epidemic by creating a special behavioral health pilot program modeled after the special diabetes program for Indians. And earlier this year, the Indian Health Service, in partnership with the American College of Obstetricians and Gynecologists, announced new clinical recommendations for healthcare providers treating American Indian and Alaska Native pregnant women and women of childbearing age with opioid use disorder. These recommendations are part of a comprehensive strategy to address the opioid epidemic in partnership with American Indian and Alaska Native tribes and communities. American Indian and Alaska Native women of childbearing age receive enhanced treatment and care when clinicians are culturally responsive to each and individual patient. I'd also like to share with you some updates from the fiscal year 2020 budget for the Indian Health Service. As you may know and be aware, on September 26th, the Senate approved a spending bill that includes $6 billion for the IHS. And while this is not a final approved budget, it does spell out the Senate's intent in their proposed funding levels for FY 2020. The bill includes an increase of nearly $238 million over the enacted level for 2019. Now that the Senate bill is approved, the House and Senate will need to work out the differences between their two proposed spending levels for FY 2020. The spending bill that was approved by the House earlier this summer includes $6.3 billion for the IHS, and the House and Senate marks indicate that Congress is building on the final fiscal year 2019 number and working toward agreement on where the funding increases should be. We'll continue to monitor congressional action on a final budget for 2020 and share updates as they become available. I recently had the opportunity to testify before the Subcommittee for Indigenous Peoples of the United States legislative hearing on advanced appropriations titled Protecting Tribal Communities from the Effects of a Government Shutdown. The topic of advanced appropriations has been discussed by tribes, tribal organizations, Oregon Indian Organization partners. It's been discussed robustly within HHS and by members of Congress since the lapse in appropriations occurred earlier this year. I shared how advanced appropriations would enable timely and predictable funding for IHS-funded programs and ensure continuity of health care provided to American Indian and Alaska Native people. This is especially true in the event of a lapse in appropriations. Some people may confuse advance appropriations with the 2-year spending authority that was granted by Congress for the IHS this year. But funds will only be available for 1 year at a time under an advance appropriations scenario. Last year's change to the period of availability for the majority of our appropriated funding means that funds that were previously available only for 1 fiscal year are now available for a 2nd fiscal year. So FY 2019 funds that would have expired at the end of September, just last month, are now available through September 30th of 2020. And this will be in addition to any new funds that are appropriated for the Indian Health Service in the 2020 budget. This shift allows the agency more flexibility for planning and obligating funding, and the change in period of availability does not in any way impact other programs that are considered X-account or no year, like our purchased and referred care programs, and those funds will continue to remain available until they're fully expended. Most recently, the President signed a continuing resolution on September 27th, and this continuing resolution provides funding for the Indian Health Service from October 1st through November 21st. And it includes a few additional items specifically for the Indian Health Service, such as an additional $19 million for new facilities that are either already open or will soon be opening during the CR period, and an additional $21 million for the special diabetes program for Indians. Today, I also want to share an exciting new development that may affect Indian Health Service funding under short-term continuing appropriations for FY 2020. The IHS has been working closely with the Department of Health and Human Services, Office of the Assistant Secretary for Financial Resources, and with the White House Office of Management and Budget, and with our own Office of General Counsel on opportunities for minimizing the impact of short-term continuing appropriations in our health systems, leading up to hopefully congressional action on advanced appropriations. Through the incredible support of both HHS and the Office of Management and Budget, we have received approval to request an exception apportionment for amounts related to Indian Self-Determination and Education Assistance Act, Title I contracts, and Title V compacts. This means that we're requesting an exception to the standard methodology for calculating the amount of money available under short-term continuing resolutions. If approved by OMB, IHS would be able to pay tribal contractors and compactors beyond the standard pro rata CR methodology. In other words, IHS would be able to pay fiscal year tribal contractors and compactors for the majority of their contract or compact amounts during the current CR period that runs through November 21st. If another short-term CR extends into or beyond January, IHS would seek similar funding levels to pay those tribal contractors and compactors that are payable on the calendar year or on other funding cycles. While we work through the exception apportionment process, IHS is issuing tribal payments with the CR funding levels that are currently available, just like we would under any normal CR. If approved, the exception apportionment would only apply to tribally operated programs. IHS federally operated programs and urban Indian organizations will continue to be funded at the standard CR funding levels. I want to assure you that the potential change I described will not in any way reduce the amount of funds available to federally operated programs or urban Indian organizations under a short-term CR. And I've been couching this is not nirvana. I think end goal is advanced appropriations, but this is HHS and OMB working together to look at what other tools might be available to support tribes so that we're not negatively impacted by CRs. Now I'd like to share a few updates on recent tribal consultations and urban confers. On September 4th, the IHS initiated tribal consultation and urban confer to seek input on the MOU and related performance measures between the Department of Veterans Affairs, Veterans Health Administration, and the Indian Health Service. Our first of several joint consultation and confer sessions on this topic was held during the National Indian Health Board's National Tribal Health Conference in Temecula, California. Consistent with our efforts to promote excellence and quality, our agencies meet quarterly to discuss and identify improvements to the MOU that will improve access and healthcare outcomes for our Native veterans. Our Deputy Director for Intergovernmental Affairs, Mr. Ben Smith, who's here with us today, will be joining Ms. Stephanie Birdwell from the Department of Veterans Affairs to meet with the NCAI Veterans Subcommittee later this afternoon. The Community Health Aid Program Tribal Advisory Group also met last month to finalize recommendations on the draft policy of the National CHAP expansion. We initiated tribal consultation on this topic back in May, and the policy will soon go out for agency-wide comment and review. I want to thank all of the CHAP TAG members for all their hard work throughout this process. And then just last week, we initiated tribal consultation and urban confer on the distribution of funding for the IHS Special Diabetes Program for Indians for fiscal year 2021. With the extension included in the Continuing Appropriations Act and Health Extenders Act of 2019, the current SDPI authorization will expire on November 21st, 2019. We do not know at this point if or when Congress will address authorization for the remainder of the final year of the current SDPI grant cycle, which runs from FY 2016 to FY 2020, or for the next grant cycle, which would be from FY 2021 to FY 2025, nor do we know the total funding amount that might be authorized by Congress. Regardless, we will proceed with the consultation and confer to ensure sufficient time for all tribal and urban Indian organization leaders to have the opportunity to provide comments. When this process is complete, the Tribal Leaders Diabetes Committee will convene to review the comments and provide recommendations to consider prior to making a final decision. The comment submission deadline is December 2nd, 2019, and more information on this particular consultation is available on the IHS website. I'd also like to remind you that the IHS Office of Tribal Self-Governance is still accepting applications for planning and negotiation cooperative agreements. These annual IHS cooperative agreements support tribes and tribal organizations with the planning and preparation necessary to assume responsibility for providing health care to their tribal members through the Tribal Self-Governance Program. The application deadline date for both cooperative agreements is tomorrow, October 23rd. As we move forward, our impact in tribal and urban communities is a reflection of the ongoing positive relationships and partnerships that we have with all of you. It's an honor to be here with you today and to share with you some of the exciting plans for the Indian Health Service in the future. I want to thank you again for the opportunity to present, and I look forward to meeting with the NCAI Subcommittee on Health later this afternoon. I think we may be in the Pickers room. Look forward to further conversation there. Thank you again for the opportunity.
So I don't know if you realize this, but the agencies are not generally, no, they're not permitted to advocate for legislation. And I know tribal leaders like me on conference calls with IHS, and whenever we see Admiral Weahkee have been pushing for advanced appropriations for a long time now. And so he didn't endorse the bill, but what he did is he found a way to support the bill by saying how, explaining how advanced appropriations would create continuity in our IHS. And that obviously had a very positive impact when members of Congress heard that. So I appreciate Admiral Weahkee finding the way to say that IHS supports advanced appropriations. So I've got a couple of quick